7, 5, 4, 3, 2, 1. We are live now.
Good evening, everybody. Welcome to today's webinar. And we have Dr. Prasad Gourineni from Tirupathi, who spends half his time in the US and half the time in India. And he's an expert on hip problems, especially at the adolescent hip. And today we are lucky to have him give us a talk today. So over to you, Prasad, and we are looking forward to hearing from you.
Great. Thank you, John.
Sure.
Hello, everybody.
Please mute yourself if you're not actually speaking, please.
I'm going to share my screen.
Yeah, sure.
Am I audible and visible? Everything, you can see everything?
Sorry,
can you guys see my screen?
Yeah, we can see the screen all right. Your voice was a little sort of trembling, but it seems to be okay now. So I think you can go on to full screen. Yeah, good. That's great.
All right.
Perfect.
I'm going to minimize this here. Okay. So my topic today is discuss functional anatomy. There's no way I can cover all the anatomy of the hip in 30 minutes, but I'll try to point out some things that you may not read regularly. So ask me questions if something is interesting for you that I don't cover. So we all know that pelvis is a ring, three-dimensional structure with tilt anteriorly. So whenever you see the pelvis X-ray, you have to keep in mind that everything is not visible. You need to interpret a little bit. The pelvis has rotation, obliquity, and tilt. These things change how you image the hip on an X-ray. Increased tilt will make the hip retroverted, the pelvis stable. Rotation also makes the side to which the pelvis rotates retroverted. So you have to keep that in mind. That's why AP pelvis is more important than a hip X-ray. Among all these things, pelvic incidence is something you need to know. That's a fixed parameter of the pelvis. Relationship will not change unless you surgically change. Not change much with the growth or anything you do. Then coming to the hip joint, you all know it's major ball and socket joint, optimally designed to provide low friction motion or a wide range of inherent stability. So variation from this ideal morphology can cause arthritis. Can, not always, can cause arthritis. And restoring this normalcy is the goal of hip preservation when indicated. So if you find abnormality, you need to actually correct it for its clinical significance, and then you can try to restore it. So keeping variations are very common. Do not cause arthritis. So you all know this anatomy. Head is round, some almost perfectly round. But keep in mind that the forehead is not supposed to bear any weight. Then you have lesser trochanter that has the muscle attached, but more importantly, for hip function, you don't want the lesser trochanter to be too close to the ischium. You just want to squeeze and rub. It doesn't have to actually touch the ischium. The touch in between that can get squeezed called ischiofemoral impingement. Then you have the neck. The neck is there to put an offset, keep the lesser trochanter and trochanter away from the pelvis. And also the trochanter, along with the neck, will give the abductor liver arm for abductor function. GT, LT can all become more prominent or less prominent. More prominent can be a problem. So the shape of these bones is important. And the neck also has an offset. If you don't have a narrow neck, you won't have good range of motion. So the neck needs to have a certain length to keep the GT and LT away from the pelvis, and it needs to be a lesser diameter from the head to have good range of motion. Then the hip also has femoral torsion, femoral anteversion, and head may be tilted on the neck. You need to pay attention to all these associated relationships. You can have coxa between the neck and the shaft. You can have a neck bend in the neck, causing coxa, or you can have the head slipping on the neck, causing coxa. So pay attention to where the deformity is. On the acetabular side, you have a semilunar fossa with no cartilage. This area is not meant for clearing. But in the situation with coxa or a reverse sourcil, the head can actually migrate medially. Most people don't think that the head can migrate medially, but it can, and cause arthritis because it's going to rub against the fossa. The ligament teres may not be very important for stability, and it's not that important for that can cause pain if the head is rubbing against the acetabular fossa. Acetabular orientation, we all think that acetabular is anteverted. I don't know the exact angle, how to measure on a native acetabular. If you measure at the top, most acetabular don't get anteverted, but as you keep coming down, all acetabular becomes somewhat anteverted. Then you have a nice thick capsule. The capsule is not that important for stability if the anatomy is normal. But with any little dysplasia or coxa valgus, the capsule will be the restraint preventing dislocation. So capsule, if you open it in a somewhat dysplastic hip, you're risking instability if you're not going to adjust the instability at the same time. The capsule also has a constriction called zona orbicularis. The function of the capsular constriction is to stabilize the head. It resists distraction of the hip when you pull on it. So it stabilizes initially. And then you know that the muscles all around, the important ones for hip function are the abductors. We don't have good abductors. Even native hips don't work very well, but total hips definitely will not be stable. Here's the capsule. One of the thickest ligaments in the body is the bigelow ligament in the front, the Y ligament. I've seen the capsule to be as thick as 2.5 centimeters. I measured arthroscopically. Only about a centimeter thick. This is the zona orbicularis, a thickening constricted ring around the neck that helps in stabilizing the head from distraction when you pull on it. So labrum. The acetabular labrum, unlike in the shoulder, it's not attached to the capsule. The labrum and capsule are separated by recess all around, and the labrum continues to the bottom as a transverse acetabular ligament, to which the ligament teres attaches. Again, to talk to you about the fossa, this is the only U-shaped cartilage that has articular cartilage, and this area in the middle is non-articular. Keep that in mind as we discuss variations in the next few talks. The purpose of the ligament, though it increases size and surface area, we do not believe that that's as important. The current thinking is the labrum forms a suction seal around the femoral head that will trap the hip and distribute the forces better. So if you cut the labrum, lose the labral seal, the force distribution may not be as ideal. Like I said again, there's a recess between the capsule and the labrum. And another fact to know is posteriorly, labrum and the acetabular cartilage can have a cleft. That's a normal variant. Though some people say there can be a normal cleft in the front also, I believe that the cleft in the anterior aspect is always pathological, usually from impingement. The labrum has blood supply on the capsular side, but even if you devascularize the labrum and sew it back, it heals nicely, like the meniscus knee. So you don't need to worry about vascularity. You can pretty much any tissue with sutures and it becomes the labrum. Here's an example of a benign cleft in the posterior aspect of the hip. This is an arthroscopic picture. This is the acetabulum, posterior labrum. This is the head distracted, arthroscopy. The capsule is cut through the portal. Is a probe, and this is a benign cleft. The way to differentiate it from any pathological lesion is the cartilage medial to the cleft. If it's nice and firm and healthy, then it's probably benign. When this cartilage is soft or damaged, then it's probably pathological. Again, look at the labrum. There's a sulcus, a recess between the labrum and the articular cartilage. And this is zona orbicularis around the neck and ligamentum teres on this MRI of a pediatric patient. Again, a pediatric patient's hip, labrum. That's the blood vessels coming into the labrum from the capsular side. No supply from the other side. But when you cut all these vessels, repair, it will heal. So a little bit of labral tears. Labral tears are not diagnostic of anything. Labral tear is the first thing that happens in most painful hips. So it's more like a pain generator, and it causes synovitis. So the three types of labral tear, the two types actually described, and I'm going to add a third type for you. So cell that's described this, type 1 is a chondrolabral separation, like the cleft we saw, or a pathological chondrolabral separation, usually from cam impingement. Type 2 is intrasubstantial tears from compression of the labrum between the neck and the acetabular rim. These are pincer type of impingement. And a third type is from dysplasia. I'll show an example to you. Keep in mind that labral tears should not be the diagnosis. You should take care of the cause of the labral tear. And labral tears heal well with or without repair, in fact, when the cause is taken care of. Is an example of a pathological cleft. This is pathological. There's all this synovitis on the labral side, and this cartilage is somewhat soft. Here's a type 2 pincer type of labral tear where the labrum got crushed between the femoral neck and the rim. It's an example of a dysplastic labral tear. This is the labrum. This is the articular cartilage. Because the head is subluxating in a dysplastic, it's able to stop the labrum with a piece of articular cartilage. If you see this type of a tear, you're very concerned that this will be unstable. If I'm doing arthroscopy or a surgical disorder, not prepared to tackle the instability, this can be a disaster, can have postoperative dislocation. So type 3 labral tear is a dysplastic labral tear. Again, the head is subluxating. It also solves a hypertrophied labrum and causes labral tear. Little bit of development. Limbus is not equal to the labrum, but it's more cartilaginous lateral aspect of the acetabular roof. Lumbectomy in DDH should not be done because limbus contributes to 30% of the depth of the acetabulum. So if the limbus is in the way when you're doing a DDH reduction, you should elevate and put the head below it rather than excising it. Worst case, you can do a small radial cut in the limbus to reduce the head. Another developmental thing to understand is the posterior wall of the acetabulum does not ossify till the child is older. The end wall is earlier. So you get an X-ray, you see a deficiency in the posterior wall, a crossover sign. And it's a false crossover sign because on MRI or morphological exam, the posterior wall will be fully developed, but it won't be visible on X-ray. Roughly, up to 2 years in girls and 14 years in boys, you suspect that the posterior wall is not fully ossified. The way to look at it is, if the cartilage is open, then you assume that the posterior wall is not fully ossified. Another aspect of development, the shape of the head defines the shape of the acetabulum. If you put a square peg in place of the head, the acetabulum becomes square. People have done studies with the triangular and other type of objects placed in the acetabulum became triangular. If you have a round head in the acetabulum becomes nice and round. On the other side, if the acetabulum is not deep and molding the femoral head will not be spherical. So what it says, the concentric of the head and the acetabulum help each other develop well. So this is one of the principles when you do DDH surgery. You don't want to accept subluxation for too long. To reduce and encourage the head and acetabulum to mold each other and develop well. Triradiate cartilage, it's usually open to about years in girls and into 15 years in boys. Injury to triradiate cartilage in older children is not going to cause much problems. Injury under 8 years age can cause what's called post-traumatic dysplasia. Triradiate growth is important, more important, under 8 years of age. And you also don't expect much remodeling after 8 years of age. Most remodeling happens under 4. and some may happen up to 5, but you don't expect any improvement after 8. And surgical procedure that surgically closes the trirated cartilage in an attempt to correct protrusion. You can actually treat protrusion by fusing the trirated cartilage and cause dysplasia. That will compensate for the initial protrusion. So subluxation of a hip in a growing child because the head is not pushing on the trirated cartilage to make it grow round. Another thing to keep in mind is even after 8 years of age, with the open triradiates, the acetabulum can still deform. It may not improve, but it can still deform. A cam deformity in an older child at 10 or 12 years old, or a SCFE, can cause lateral elevation of the lateral acetabulum lip and cause dysplasia of the acetabulum. Here's an example of normal hip. Patient had an injury. He's a callus from a trirated cartilage injury in a young child, 4 years. When he's 17, you can see the classic post-traumatic acetabular dysplasia. The teardrop is wide. Not only wide, it has this funny shape, right? And it's always retroverted. The posterior wall does not develop as much as the anterior wall does. So there'll be a retroversion or overcoverage front and dysplasia more posteriorly. Very classic way. When you see this, you can call it post-traumatic, even if you don't have a history of trauma. An example of false crossover sign, where the anterior wall is fully developed and the posterior wall is going straight up, lens deficient. But this is false because the trirated is still open, the posterior wall is still not fully ossified. Here's a case example to drive this point well for you. A 12-year-old male, my patient, the left hip was dislocated. In an outside facility, they closed, reduced it, and transferred the patient for further care. And we got a CT scan, that's a standard. After traumatic dislocation, we got a CT scan, and all we saw was a few small flecks of bone pieces. So initially, we thought they're insignificant. This is a normal side of unossified posterior wall. You can see an outline here. When I measured it on CT scan, came to about 23 millimeters. So if you look at the injured side, where the deficiency is, and put all these flecks together, they all seem to have a constant relationship and seem to be part of a big single piece. Okay, AP, not AP, but a cross section. Put all the pieces together, that's about a 20 millimeter segment. And this patient had a big posterior wall piece that took 2 3.5 millimeter screws. So to put 3.5 screws, 2 of them, the piece has to be at least probably 15 to 20 millimeters in size. And that's a very big chunk in a patient. And this is very unstable when we examined anesthesia. And after we fixed it, it became stable. So we put buttress plate. So in a pediatric patient, because there's unossified posterior wall and also cartilage can be fat, is better than a CT scan after reduction. Femoral growth. The head and the GT have a common growth center. So any imbalance between the growth of GT and the head can cause a deformity. The GT overgrows, you get coxa vara. The GT is inhibited, you get coxa valga. So GT inhibition is more from abductor weakness. And if there's a tether between the head and the GT, you get caput valgum. The head goes into valgus because the head is not allowed to grow normally on the lateral aspect. And another thing about femoral growth is a lot of stress, jumping and running stress in a pediatric patient between 5 and 10 years of age. So that puts a lot of pressure on the head. It will cause epiphyseal extension. The epiphysis grows onto the neck and forms cam morphology or a cam defect. This considered to be the leading cause of cam impingement, cam morphology. Most active children have cam morphology. Now, the blood supply of the femoral head. Most textbook show a nice vascular ring, extra capsular ring, and then they also show a subsynovial ring of tongue anastomosis. But a more recent study, not recent actually, even as old as when Sevitt and Thompson from 1961, I'll show you some slides, there is no real anastomosis. This particular vessel, as you see here, femoris, lateral circumflex, medial circumflex. The lateral circumflex is predominantly is the most important blood supply to the hip on the anterior aspect. Anything you do anteriorly. Can you guys hear me? My internet connection is not as stable. Can you hear me?
We can hear you
Yes.
most of the time. In between, the voice kind of cuts off, but otherwise it's okay.
I'm sorry.
Yeah.
For some reason, my connection is not very stable right now.
Yeah, it's okay. I think we are managing to understand most of it. There are a few words which get cut off. Yeah.
Okay. Again, you see the lateral circumflex, a big vessel in the front. Most anterior approaches will do some damage and ligation on these vessels. A single branch goes to the head. It supplies the capsule in the front, supplies everything in the neck, but not the head. And there is no anastomosis of lateral circumflex to medial circumflex. The medial circumflex goes around to the back, right in the bottom here, supplies the vessel to the head at the bottom, lower 1/3, then goes around and supplies the rest of the head. Here's again, this is the posterior aspect now. Medial circumflex coming around. This is the medial synovial fold vessels, inferior epiphyseal vessels. Ascending branch goes up and supplies most of the head on the top. And this anastomosis does not exist. We operate on hips all the time and look at this area, and there's anastomosis between medial and lateral circumflex arteries. This is from Gans's article. Professor Gans did a lot of cadaver studies. Again, this vessel, the ascending branch, comes along the obturator rectus muscle, goes over it, and dips under the gemellus inferior, and then goes into the capsule. So this is the vessel you want to protect anytime you do a posterior approach. It's not a total head. If you're doing any trauma, any other procedure in the back, you want to preserve this vessel. So the best way to preserve it is you cut your tendons and rotators more medially so that you leave at least 1 centimeter from the GT to protect this vessel. So this quadratus femoris, this vessel comes between quadratus and the obturator externus. You don't see obturator externus when you're actually dissecting, but you cut it all the time when you do posterior approaches because you see only the tendon usually. When you take out all the muscles, this is the blood vessel going up. These vessels, about 2 to 6 branches, are the most important blood supply to the head. And here, if you leave the obturator externus muscle still attached, it will prevent stretching of this vessel, even with wide dislocation of the hip up to 6 centimeters away from the socket. You can dislocate very wide, but this will be your protector of the vessel. So as long as you don't cut this, you can dislocate the hip widely and not cause AVN. Again, another nice ascending branch coming up. Terminal branches, lateral epiphyseal vessels to the head. And these are in the posterior half of the head. Posterior, on the lateral aspect, this is the lateral aspect of the head and neck. The anterior half does not have all these vessels. And then anteriorly, there are no vessels at all. Posteriorly, there are no vessels. Inferiorly, the medial vessel, a small branch to the lower 1/3 of the head. So if you know this blood supply and preserve it, you can pretty much do any preservation surgery. So there is a cruciate anastomosis of 4 vessels on the lateral trochanter, but has no importance at all. But the more important is anastomosis. There's a branch of inferior that comes along the bottom of the piriformis. I'll try to show you. There'll be a branch coming this branch. This is anastomose and can be a predominant blood supply. So if you preserve this vessel, it will be nice to have an extra more blood supply to the head. So that's an important blood supply. lateral circumflex does not contribute to the head, only supplies the capsule and the neck. Superior gluteal and iliopsoas supply by sternum. Here this vessel again, inferior gluteal branch coming at the bottom of the piriformis. So your dissection, when you do surgical dislocation, should be proximal to the piriformis and not below the piriformis. A 1961 study in JBJF by Sevitt and Thompson, they studied the blood supply. They found that this vessel has on its own. Let's see that. They cut every blood supply there. Every aspect, the neck is osteotomized, kept only this vessel intact, and that could supply the whole head. And when you cut that vessel, the head becomes ischemic. So it's vitally important to preserve the vessel. Sorry, again, my connection is unstable, it said. Okay, when you cut this vessel and keep everything else intact, still most of the head will be not viable. Here's the basis for head reduction osteotomy. You can split the head right in the middle, still not cause AVN, because the bottom is supplied by the medial epiphyseal vessel, and the top is supplied by the lateral epiphyseal vessels. So both can have intact blood supply while you work in the middle of the head and actually reduce the size of the head in coxa magna, or when it's deformed, you can actually make it rounder by excising the middle part of the head. This side, most of the blood supply comes from ladder blood coming down. There's obturator artery that supplies blood supply. When you do a periosteal osteotomy, destroying all the vessels, and the only thing left is this obturator artery. So the blood flow comes down to 30% of what's normal after a periosteal osteotomy. And imagine doing a closed osteotomy, like spherical osteotomy, rotating the sternum around. Even this can be disrupted. That's the reason why spherical osteotomy is a significant risk of AVN. But does not cause AVN. Yes.
I think maybe if you shut off your video, you might be able to get slightly better sound, because again, it's getting very disturbed.
How
we
do
have
I
done
shut
that.
off my video? Oh,
Yeah,
video.
we have done,
Just,
sir.
you have stopped video there?
I have done, sir.
Okay.
Already. Yes, sir. So no.
Thank you. All right. Sorry. I'm almost, yeah, okay.
Yeah.
So the sternal side, periosteal osteotomy leaves only one good blood supply, while a spherical osteotomy too close will disrupt even that. The most important supply is a branch from the iliolumbar artery that supplies the sternum. But this is always disrupted when you do a periosteal, any stellar osteotomy. This vessel is disrupted. So the big anastomosis. So AVN of sternum is very uncommon because there's a lot of anastomosis intraosseously. We did a study that we're trying to publish. It's in review. When we did total hips and cut the lateral epiphyseal vessel, about 20% of head still bled briskly, saying that there is alternate blood supply even if these vessels are disrupted. I'm not recommending that you cut these vessels, but damage to vessels do not lead to AVN all the time. To support this, HealthFed did 2 or 3 MRA studies that showed intraosseous anastomosis between all these different blood supplies. So the head has a blood supply from the lymph to the perifoveal area, the bottom from the medial epiphyseal vessel, and from the top on the lateral epiphyseal vessels. And adults will have some blood supply through the neck to the head. So these things can take over when the lateral vessel is disrupted. That's why you don't see AVN every time there's an injury to these vessels. Intramedullary rotting damages this vessel to a significant effect if you go to the piriformis fossa. But most adult patients with IM nailing do not get AVN, right? The other thing is most people who do posterior approaches to the sternum may disrupt the medial circumflex sometimes and still don't end up with AVN at high rate. Keep that in mind, there's some anastomosis. So it's not a done deal, but at the same time, don't damage the lateral vessels if you can avoid it. Any questions on that? I can elaborate on anything that I didn't cover.
So,
That was excellent, Prasad. Unfortunate that sometimes the sound was kind of getting disturbed. You can switch on your video now, Prasad,
Yes, sir.
Okay.
because now it's should be okay. So there are some questions on the chat box.
Yes.
Maybe we should take those, some of them.
Yes, sir.
Janki, you've got them?
Yes, sir. I have got it. So, Dr. Mojimal asked, "What can you please elaborate the relationship of pelvic incidence to acetabular cup version in THR and how to optimize cup placement properly in such cases?"
So if you have if you have increased incidence, normal is about 50 to 60. If you have more than that, your acetabulum will be more retroverted, native acetabulum. You have more lordosis and more pelvic tilt. So then you need to put less anteversion in your cup. The incidence is less, where you have a flat back, less lordosis in the spine, and sort of posterior tilted pelvis. Your acetabulum is anteverted, native acetabulum, risk for anterior dislocations. You want to put a little more retroversion.
So,
Yeah.
the other thing,
So
yeah.
there was a request from somebody to elaborate on the blood supply once again.
Okay.
Just without the diagrams.
Sir, actually, what happened that time, the slide was lagging behind. So what he was explaining, that was not proper. That's
Yeah, I know.
Okay.
But
Well, most of you can visualize when I talk to you without the slide.
yeah.
So the blood supply to the hip joint in general comes from medial circumflex, lateral circumflex, superior gluteal artery, and the obturator artery. Four. So the obturator artery supplies the acetabulum, most of the acetabulum inferiorly, and a branch through the ligamentum teres called foveal artery to the head, and supplies the perifoveal area usually, just around the fovea. Does not contribute much to the weight-bearing dome of the femoral head. The superior gluteal artery supplies most of the acetabulum superiorly, but there's a big anastomosis with the iliolumbar branch from the other side. The acetabulum blood supply is pretty robust unless it's a revision surgery. Primary acetabular surgery, most osteotomies do not cause any AVN of the acetabulum. On the femoral side, the blood supply is predominantly lateral circumflex anteriorly to the capsule and the femoral neck and the GT area. All the vessels you see in an anterior approach that you see bleeding at the hip capsular level are all lateral circumflex vessels. However, not a single branch goes to the head in adults or children. So lateral circumflex can be ligated without risking any AVN. That's why anterior approaches do not cause AVN by themselves. Now, posteriorly, the medial circumflex starts anterior actually, right? It's a branch of profunda. It arises in the femoral triangle, goes back over the iliopsoas tendon, the psoas tendon, and as it reaches backwards, it follows the inferior border of the obturator externus muscle. And the obturator externus muscle goes from front to back to the muscle that inserts into the piriformis fossa is not piriformis, it's obturator externus. So this goes along the inferior border of the obturator externus tendon, and right before its insertion, not right before, a centimeter before its insertion, it crosses over posteriorly over the tendon like you saw on that image. Then this ascending branch penetrates the capsule underneath the inferior gemellus. Once it penetrates the capsule, it forms the lateral epiphyseal vessels that go along the neck, the posterior half of the lateral neck. Very top of the neck, you call it lateral. The posterior half is where these vessels lie in a synovial sheath. It's called lateral synovial fold. This supplies most of the head. Even if all sources are cut, this can supply the blood supply to the entire head. This vessel receives an anastomotic branch from the inferior gluteal artery. This branch comes along the inferior part of the piriformis. Some people call it a piriformis branch. It anastomoses with the ascending branch before it enters the capsule. And in some specimens, this seems to be the predominant blood supply to the head. So you cannot preserve it in any posterior approach. And maybe cutting this can contribute to AVN, this branch. Even if you preserve the ascending branch of the medial circumflex, you can still cause it because some hips rely on this vessel more than the ascending branch. Before the ascending branch goes to the top, it gives out one vessel inferiorly at the neck. It's called medial epiphyseal vessel, right at the bottom of the neck. This follows a ligament called ligament of Whitebread or medial synovial fold. It follows the posterior border of this fold and goes to the bottom of the head and supplies about 1/3 of the head usually. But what we now know is, based on MRA studies, that a lot of these vessels actually anastomose in the head, and even if you disrupt one vessel, the other will take over. So AVN is not inevitable if the major vessels are damaged, but again, you should know the anatomy and protect it so that you don't take a risk. Is that clear?
Yeah.
Yes, sir. So one thing they have asked is about anatomy of ligamentum teres, its origin, insertion, and role of ligamentous teres reconstruction, explained in the last lecture.
Okay. Good question. So ligament teres is attached to the transverse acetabular ligament on the acetabular side. It's a regular ligamentous structure that goes and inserts into the fovea capitis in the head, a depression in the head. And it's always, normally it should be below the center of the head. The fovea is an inferior structure on the medial aspect. This fovea should never come up to the articular surface of the acetabular, should not touch, right? Because this is non-weight bearing. Ligament teres is the stabilizer. Every time a hip dislocates, the ligament teres has to tear. And ligament teres is cut every time I do surgical dislocation, intentionally, surgically. When I dislocate a hip, right, surgically, we are cutting the ligament teres to go in. So cutting the ligament teres does not have much consequence on the blood supply to the head. Does not cause any ischemia. In the bottom line here, it can contribute instability. If the acetabular is dysplastic and the ligament teres is trying to hold it in place, it can contribute to instability, but usually you should not dislocate or do any arthroscopic surgery of a dysplastic hip that's going to rely on the ligament teres. So my opinion on reconstruction is most hips don't need a ligament teres. When I actually dislocate, half the time the ligament is so weak, it just pops on its own. I don't need to cut it. And in the half that do not pop, when I try to dislocate, I'm going to cut it with scissors. And even then, nothing bad happens to the head. So reconstruction does not have a role in my practice, in my opinion. And if a hip is dysplastic and needs ligament teres reconstruction to maintain it, that's not the right operation. You probably should stabilize the hip with the acetabular osteotomy.
Okay. There's a question about widened teardrop. What are the causes?
Yes. Okay. So widening the teardrop happens when the head is not pushing on the acetabulum to make it grow nice and deep. So it's exactly opposite of a deep acetabulum. So widened teardrop is a sign of acetabular dysplasia, but it's not pathognomonic, because you can see somewhat of a wide teardrop and still have a decent sized acetabulum. But in general, when you see a widened teardrop, you think that the acetabulum is dysplastic and start to look carefully to see if there's any instability of the hip. If the head is subluxating or the acetabular source is steep, and that can, confirm that the acetabular is dysplastic. So widened teardrop means dysplasia, and a narrow teardrop or a reverse teardrop. So teardrop is formed by, usually a normal U-shaped teardrop is formed by, on the medial side, by the Kohler's line. Kohler's line is an ilioischial line, posterior column line. On the lateral aspect, the teardrop U is formed by the floor of the acetabulum, the acetabular fossa. So a nice narrow teardrop tells you that the acetabulum is nice and deep. But if the two limbs of the U meet each other, that's a sign of a more than normal, deeper acetabulum called coxa profunda. And if the teardrop can reverse and goes the other way, it's more severe profunda, and the head touches the Kohler's line, that's protected. So wider is dysplastic, and a very narrow or reverse teardrop is deep acetabulum or protrusio.
So also, but just to remind people that the teardrop is not an actual structure, but a radiographic picture that you see on, and it doesn't actually correspond to a particular structure in the acetabulum.
Yes.
So another
The
question
lines are
asked
formed by this structure. We know the lines are formed by a structure,
Yeah.
but it's not a teardrop structure.
Yeah.
So, Dr. Mohammed has asked what single most important arterial supply of femoral head. Actually, in the DNB paper, sir, they have asked many a times, according to age, what is the supply of the femoral head. So, just elaborate on that one also.
If I take
Single
your exam,
most-
I may fail, but I'm going to tell you that most important at any age, it's a lateral epiphyseal vessels.
Epiphyseal vessels through the capsule.
So MFC, if they give you a choice, is medial circumflex femoral artery, and among the branches, the ascending branch and the lateral epiphyseal vessels is the most important blood supply at any age. It becomes less important maybe when the physis closes, but still, the Seviton-Thompson study is entirely in people with the closed physis. They're like cadavers.
Yeah, because by that time you'll have some intraosseous vessels as well, I guess.
Right.
So, one question about the micro instability of hip. What is that?
So micro instability is I won't say vague, but it's not a definitive diagnosis. There's no way to say, there's no real way to diagnose it. People go by all these indirect signs. Somebody has ligamentous laxity. You pull on the leg for any type of arthroscopy and it comes out pretty easily, easy distractibility. So ligamentous laxity, easy distractibility are the criteria to cause something micro instability. Again, it's one of those things where the arthroscopy is created. Professor Gans and the Swiss did not think that there's anything called micro instability. This happens if the sternum is nice and deep, it doesn't matter how loose the ligaments are or how easy it is to distract. So they know micro instability of the bony structures are nice and well formed. It's in the borderline cases where the sternum is, say, 25 barely or 24, 30, 23 degrees of LCE, lateral centroid angle, and the head is somewhat a little valgus. It's not quite subluxated, but can subluxate at any time type of anatomy. Then that relies on the capsule, like I said in the beginning. And if the capsule is not intact, you can have symptoms from the head being somewhat loose, easily moving in and out, right? It's not dislocating or subluxating, but it just has this extra motion because the bony structures are not deep enough and well formed. And the capsule is also not very intact. So for this micro instability, it's again, the bones have to be deficient enough to cause it. And it's particularly seen in people with the ligamentous laxity. Now, there are signs people come up with saying that this is more common in people with looseness and said there's a divot sign on anatomically, intraoperatively or on MRI scan where there can be a divot on the head. That one of my friends published saying that 86% of instability patients had a divot in the head neck junction. Another person came up with the finding that a cliff sign on X-ray where the head is not quite round on the AP view and has not a cam, but opposite, a defect at the bottom called cliff sign. These are supposed to be signs of instability, but they're associations. They cannot be really causative or an effect of instability. And both are refuted. I don't think both are correct, actually, just because they found them. The diagnosis of instability itself is vague. And then just a finding of an association is also not very correct. So I don't believe that micro instability is a real thing. It's just a subtly dysplastic hip.
So we can call it snapping hip, sir, because
snapping hip is a totally different thing.
Different entity. There are
DFL.
Yeah, there are two types of snapping hip. There's internal snapping and external snapping. The internal snapping is most often from the iliopsoas going medial and lateral of the iliopectineal eminence, the bony prominence on the pubic root, where it joins the acetabulum. So in abduction, flexion, and external rotation, the tendon is lateral. And when you straighten the hip down, extend, internally rotate, and adduct, the tendon moves anteriorly. And you usually hear a loud snap. The rule is internal snapping, you can hear it across the room. And external snapping, you can see it from across the room. External snapping is IT band. Now, let me finish up internal snapping. A few other things that can cause internal snapping are an unstable labral tear, a little loose body in the front, or some capsular band can cause some snapping. But the loudest snap is iliopsoas moving around. It may not be painful, but it will be very loud. Externally, it's the IT band. Gluteus maximus insertion on the back of the IT band can be very thick and can move on the greater trochanter. You can elicit it, but often the patient can himself show it. They come saying that the hip is going in and out. They think the hip is popping out of place. The hip does not pop out of the place. It's a band moving on the greater trochanter. And this external snapping. It's called IT, it's not called, but IT band is thick and snapping on the GT.
Yeah.
So they have asked about alpha point.
Alpha point. Who knows about alpha point?
Yeah, the
We
Dr.
didn't even publish it there. The alpha point is not even published yet. I just wrote the paper.
Oh.
Anyway, you know, alpha angle is well established. Alpha angle is a measurement of the sphericity of the head.
Yes.
So the point of asphericity, when you take it, to draw a line from that point of asphericity to the center of the head and then along the neck axis, the angle between that is alpha angle. So we wrote a paper recently to differentiate slips from idiopathic CAM and also CAMs that developed after a SCEPI and called that point of asphericity for simplicity as the alpha point. And the paper got accepted by IGO, but I don't think it got published yet. So alpha point is a point where the head becomes aspherical. If you put a perfect circle on that head on an X-ray, where the bone goes out of the circle is the point of asphericity, and the other name for it is alpha point.
Okay, great.
So just one last thing about the common thing usually asked in the DNB, sir, is the pincer and cam FAI. So just on the radiological point of view, what is important for DNB? Just explain that.
All right. For DNB, the answer will be cam impingement is always from the femur and pincer is always from the acetabulum. That's what exams say. Reality-wise, cam is always from the femur. Pincer can be from both, but don't answer this in the DNB like that. In the DNB, you say cam is femur and pincer from the acetabulum. Acetabulum overcoverage, acetabulum retroversion, things like that will cause pincer impingement, and aspherical femoral head is cam impingement.
So you can
And
otherwise
most common
call
presentation is both. A mixed type of impingement is the most common presentation. 80% of mixed have both morphologies.
So basically, when the acetabular wall is kind of pinching on the head, that's what you call the pincer. And when the head is sort of shaped abnormally so that it's impinging on the acetabulum, you call it a cam effect. But like Prasad said, most of them are combinations rather than just one particular thing. But one may be more predominant than the other.
Yes.
And let me just clarify one thing. Cam morphology is different than cam impingement.
Yeah.
If you take an X-ray of everybody here, more than half of us will have big cams, no symptoms and no pathology. So cam morphology should be differentiated from cam impingement, which is a clinical diagnosis. Or you base the diagnosis on damage pattern. You should be able to see some cysts in the head, tears in the labrum, cartilage delamination, and things like that to pathologically diagnose it. Otherwise, it's an intraoperative pathological diagnosis. So X-ray wise, you cannot say cam impingement, you can say cam morphology. Same thing with pincer morphology. Overcoverage does not mean that they have impinged. A lot of people with overcoverage don't impinge. So that's a normal variant.
Yep. Okay.
So I think we have taken most of the questions. It was great. So just a little bit of difficulty during the lecture. Otherwise, now it's quite okay.
Yeah, I'm
sir.
sorry.
Yeah. No, thank you very much, Prasad. That was great. And hopefully we'll have you again in the near future with a slightly better sound. But I'm sure that is a problem that we can't do much about at the particular time. But I think most of it could be heard. It's just some patches which we couldn't hear very clearly. So thank you very much. And it was, as usual, a very illustrative talk on the hip and its anatomy, and I'm sure we'll have subsequent talks on other pathologies around the hip, and we look forward to hearing that from you, Prasad. Okay.
Thank you, John. I'll be glad to come back. Yeah.
We'll go through the video set today so that if something is not clear in the next lecture, we can ask you to include that one.
Definitely.
Yeah, sure.
All right. Good night.
Okay.
Thank you very
everybody.
much. Sir.
Good night.
Yeah. Thank you, sir.
और देख रहे थे क्या आप? अच्छा लगा? रजाई पे बैठा था, रजाई पे ना किया हूँ।
मम्मा अपने मारा।
सॉरी। कर ले तो।
आपका आपका आपका